Is the thyroid gland. In the thyroid gland, just like parotid gland, the relations are again very important. In the tracheostomy, we have to cut through the isthmus of the thyroid gland, so we need to know about the relations of isthmus, and also for the lobes of thyroid. Certain clinical questions like if there is a swelling of the thyroid gland, it will move in what direction, what is restricting it going from above or going downward. So to answer all those questions, we first got to start with the extension and the location of the thyroid gland. We'll be talking about the coverings, the true and the false capsule, and then we'll get into the relation part. Okay, so guys, if let us say, let me draw it for you. If here is a thyroid cartilage, when you see it from the front, this is a thyroid cartilage here. The thyroid gland is located in such a way, this is, let's say, the right lobe of the thyroid. We got a isthmus, and there is a left lobe. So, a few important points to be noted before we talk about in detail about the relation. That for the location of the gland is against C5 to T1 vertebrae. If you are comparing with the vertebral column, the location of the entire thyroid gland is from C5 to T1. C5 to T1. So it is somewhere starting from this middle of the thyroid cartilage. If this is a thyroid cartilage, so let's say it starts somewhere from the middle of the thyroid cartilage. From the middle of the thyroid cartilage, and it is extending all the way to the fourth or maybe fifth tracheal ring. It extends from fourth to fifth tracheal ring. So that is a vertical extension of the thyroid gland. Somewhere from the middle of the thyroid cartilage, there is a line called as oblique line. So it starts below the oblique line and it is extending till the fifth tracheal ring. Whereas if you look at the isthmus part, that is the isthmus connecting the two lobes of the thyroid. The isthmus of the thyroid gland, it is present, it is located against second to fourth tracheal ring. Second to fourth tracheal ring. They do ask this question, especially about the location of the isthmus. The location of the isthmus of thyroid gland is from the second to fourth tracheal ring. So when you compare it to the vertebral column, it is from C5 to T1. And when you look at the structures out in front, the skeletal structure in front, you compare with it. So it is starting somewhere from the middle third of this thyroid cartilage below the oblique line of thyroid cartilage and then extending till the fifth tracheal ring. Isthmus, whereas, is located against second to fourth tracheal ring. Certain structures which are covering the thyroid gland from the front and holding the thyroid gland from behind. To understand that, let's take an understand a schematic line diagram from the side. So if you have a side view of the thyroid gland, let's say, if this once again is a thyroid cartilage, guys, but this time you're looking at, let's say, thyroid cartilage from the side view. Here is the oblique line of thyroid cartilage. There's a line called as oblique line of thyroid cartilage, and here is the gland. Now there are two questions to which you should get the answer by looking at this diagram here. Now obviously there will be a cricoid cartilage here below. Oblique line of thyroid cartilage is providing origin to certain muscle, like we have a thyrohyoid muscle attached here and certain muscle which are going downward also and backward also, like we have a constrictor muscle going backward and the strap muscle going downward. Now one of the strap muscle, we'll be discussing these relations separately as well, but one of the strap muscle that you will see coming from below and attaching to this oblique line of thyroid cartilage, going like this and attaching here, that muscle is the sternothyroid. That's a sternothyroid muscle. It's coming from the sternum and attached to the thyroid cartilage, and it is passing in front of the thyroid gland and then attaching to this. Sternohyoid muscle obviously will go even higher. If this is sternothyroid, and if let's say if I have to present the sternohyoid also, that will go to the hyoid bone. So sternohyoid muscle will be going in this manner, and it is must be going all the way to the hyoid bone. That will be higher. So both are strap muscles only, but what is to be seen here, the sternothyroid muscle is the one which is more closely related to the thyroid gland, attaching to this oblique line, and that is the one which is preventing the swelling of the thyroid gland to go in the upward direction. We know that thyroid swelling, they go into downward direction only. Why the thyroid swelling are not moving in the upward direction? Because which muscle is stopping it? It is a sternothyroid muscle. It's not the ligament, guys. It's not the ligament of Berry which is preventing the swelling from going inside. The question is about not the normal movement of the thyroid. It is about the swelling of the thyroid gland are not moving upward, and that is because of the muscle that is a sternothyroid muscle. So let me write that here only, that this is the muscle which prevents thyroid swellings to move upward. Prevents thyroid swellings to move upward. Now there's another question. The another question here is, thyroid gland move up and down. It does move up and down with the deglutition. And why it is moving up and down with the deglutition? Because in the deglutition, the thyroid and the cricoid cartilage will be moving. That means there is something which is connecting the thyroid gland to this cartilage behind. The deep fascia which is covering the thyroid gland is the pretracheal fascia, right? We have a pretracheal fascia around the thyroid gland. So if I just put a fascia around it, that's a pretracheal fascia. That's a pretracheal layer of deep cervical fascia, or you can simply say pretracheal fascia. There's an extension of the pretracheal fascia which is attaching its posterior surface to the cricoid cartilage. There's a cricoid cartilage below. This is a cricoid cartilage here. And you can see this ligament here which is connecting, which is an extension of pretracheal fascia, connecting it to cricoid cartilage, is called as suspensory ligament of Berry, or simply Berry's ligament. Suspensory ligament of Berry. So one question here is that what exactly is a suspensory ligament of Berry? Well, ligament of Berry or suspensory ligament of Berry is a modification or thickening of prevertebral fascia posteriorly, attaching it to the cricoid cartilage. So every time the deglutition takes place, then obviously when the cricoid cartilage will move up, it will also pull the thyroid gland along with it. But presume that thyroid cartilage and cricoid cartilage are in their position. We're not talking about the deglutition. If there is some swelling of the thyroid gland is there, that is not going to move upward, because which muscle is stopping it? The sternothyroid muscle is stopping it. It can go downward but not in the upward direction. So just be careful what these two questions are, because people write these answers interchangeably. Swelling of thyroid gland does not move in the upward direction because of the sternothyroid muscle, but thyroid gland move up and down with the deglutition because something is attaching the thyroid gland to the cricoid cartilage, and that modification is called as suspensory ligament of Berry, which is a modification of pretracheal fascia. Talking about the pretracheal fascia, now the capsule of the thyroid gland, just like parotid gland, here also we have a true capsule as well as a false capsule. So moving on to that part, in the thyroid gland, if we talk about the capsule of the thyroid gland, we got the true capsule. And once again, the false capsule. Same story, guys. True capsule is the condensation of fibrous stroma. The gland's own stroma is forming this true capsule. And false capsule is the pretracheal fascia. The pretracheal fascia is forming the false capsule. Now there is an important comparison that is to be done between the thyroid gland and the prostate gland. We do have a true and false capsule for the prostate also, and the same story we have in the thyroid gland also. Now what that comparison is, if you look at a thyroid gland, if let's say this is the thyroid gland, if I talk about here, and here let's say is the prostate gland. So let's presume this is the true capsule for the thyroid, and this is the false capsule. I'm just purposefully drawing this gap in there. That is a false capsule. Same for the prostate. This is a true capsule, which is from the stroma itself, and the pelvic fascia around the prostate gland will form the false capsule. I'm trying to compare the thyroid and the prostate. Look at the space between the true and the false capsule here, and look at the space between the true and the false capsule here in the prostate gland. When we talk of the venous plexus, in the thyroid gland, the venous plexus is present deep to the true capsule. So your venous plexus will be present like this. That is in case of what? Thyroid gland. Guys, this is true. This is the false capsule outside, and the one, this is a true capsule inside. And let's say this plexus here that you see inside here, that is a venous plexus. But that's not the same thing that we have in the prostate gland. We have a true and false capsule, and the venous plexus is present between the two. The vesicular venous plexus, so something called as vesicular venous plexus, which continues around the prostate gland also. So that venous plexus is present between the true and false capsule. Once again, this is the false capsule outside, this one is a true capsule, and this is the venous plexus. And that's why the surgical approach to both the gland is different. Why it is different? Because in thyroid gland, you can remove the thyroid gland along with the true capsule. See, if you remove the thyroid gland along with the true capsule, then obviously your venous plexus is inside the true capsule only, and that will not any tearing of those veins and will not lead to the bleeding in that region. So thyroid can be removed with true capsule. It can be removed with the true capsule because venous plexus is inside the true capsule. But the problem with this one, if you remove the prostate gland with the true capsule, then obviously you will be eroding this space, the one which is between the true and false capsule, and that will lead to all the veins which are the vesicular venous plexus or the prostatic venous plexus which we have will lead to the bleeding in that region. So when you remove the prostate gland, we leave the scrape of the prostate gland all around it. So we just have to remove the central part of the prostate gland, leaving some part of the gland outside. So my incision plane, the plane of the cleavage here, if I talk about the plane of the cleavage here, it will be like, if I'm using a different color, guys, if the plane of the cleavage here is this, I'm putting this red line for the thyroid gland, you can put a incision in that region between the true and false capsule, and you can remove it. This is the cleavage plane. But that cannot be done in the prostate gland, so the cleavage plane will be inside. So you'll be leaving some part of the gland. You will leave some peripheral part of the gland outside, so that both in true and false capsule will be left inside, and you can remove the gland here. That is a cleavage plane here. So in thyroid gland, thyroid can be removed with true capsule. You cannot do the same with the prostate gland. You cannot remove a prostate gland with a true capsule, because if you do so, you will erode these veins which are the prostatic venous plexus, and that will lead to the alarming bleeding or hemorrhage in that region here. So that's the difference between the true and false capsule of the thyroid and the prostate gland. It's about the location of the venous plexus where it is there. So when we'll discuss the prostate gland, we'll talk about this again in detail. Right now we need to understand that venous plexus of thyroid gland is inside the true capsule. Now we come on to the relation part. We already discussed the transverse section of the neck region, in which we saw that thyroid gland is covered with this pretracheal layer of deep cervical fascia, and we saw that carotid sheath was present posterior to it. So we can use the same kind of diagram again to understand better the relations of the thyroid gland. So I'm not going to draw the entire transverse section. So let's take the TS of the neck and we'll find out what are the relations of the thyroid gland. So there we go, guys. If this here is the esophagus, And there's the trachea. And we said thyroid gland is located in this way. Right, that's the thyroid gland. When we talk about the surface of the thyroid gland, we have a lateral surface, or sometimes we call it anterolateral. This is a medial surface, and the one surface, this is their posterior surface. So we have a lateral, medial, and posterior surface of thyroid gland. Now, when you look at the lateral surface or the outer surface, you say the strap muscles are present there. If you remember, we said pretracheal fascia is having two layers. We have a muscular layer of pretracheal fascia and we have a visceral layer. The visceral layer of pretracheal fascia is enclosing the thyroid gland, whereas the muscular layer of pretracheal fascia will be enclosing the strap muscle which are present outside. So if I start immediately outside this gland here, what muscles I expect to see? The muscle that you will see in here, we have sternothyroid muscle. We just discussed that sternothyroid, which is preventing the thyroid from going up. Sternothyroid is the closest one to it. More outside you go, you have omohyoid, the superior belly of omohyoid, and sternohyoid. Superior belly of omohyoid and sternohyoid. And of course, the outermost muscle is a sternocleidomastoid that we saw, which is inside the investing layer of deep cervical fascia. So thyroid gland is partly covered by the sternocleidomastoid also. So we'll be writing these relations here only, guys. This muscle is the sternocleidomastoid enclosed in the investing layer. The muscle here is sternohyoid. This one here is the superior belly of omohyoid. Superior belly of omohyoid, and the closest one which is preventing the thyroid swelling to go upward, that was what? Sternothyroid. So please note that these four muscles in that sequence are forming the lateral relation of the thyroid lobe. These are the lateral relation of the thyroid lobe. As I said, thyroid lobe can be divided into lateral, medial, and posterior. So that's a lateral relation. Just think about the strap muscles, and beyond that, we have a sternocleidomastoid also outside. Sternothyroid is there, sternohyoid is there, superior belly of omohyoid, and outermost we got a sternocleidomastoid. Okay. One which was very simple was posterior. Guys, posteriorly we got carotid sheath. So when it comes to the posterior relation, you just have to think about this carotid sheath. You already know the carotid sheath content. We got a artery, common carotid and internal carotid artery is there, internal jugular vein is there, and we got vagus nerve in between. Vagus nerve in between. So carotid sheath and its content. You just have to say carotid sheath and its contents. They all come under what relation? They all come under the posterior relation of thyroid gland. See, these glands sometimes are needed to be removed surgically. That's why the relations are important. We don't have to remember and understand the relation of anything and everything. Glands relations are anyways important because you may have to surgically excise these glands. Posterior relation, lateral relation. Now coming to medial relation. Now medial relation, there is an easy way to remember it, guys. When you think about medial relation, the rule of two will work here. Two tubes, two muscles, two nerves. Two tubes, two muscle, two nerve. Now the medial relation, starting with this. Medial relation of thyroid gland can be remembered with this first thing, two tubes. Now you can clearly see the two tubes in the picture. What are two tubes? We have trachea and esophagus. There's a trachea and esophagus which are like medial to it. Two muscles. Which two muscle we expect to see there, guys? If this is the trachea in here. Obviously, above we have a thyroid cartilage. So what muscles, when thyroid gland is covering this, thyroid gland is partly covering the thyroid cartilage and cricoid below. Thyroid cartilage was giving origin to the inferior constrictor muscle going backward. And one muscle of the larynx which is present outside is cricothyroid. If I just take you back to this picture for a second and make you think about the muscle. Now the muscle that we know coming from the thyroid cartilage, the muscle that originates from thyroid cartilage and will go backward like this, that will be the constrictor. That is what constrictor? Inferior constrictor will be there. Inferior constrictor. More precisely, thyropharyngeus part. And between the thyroid and the cricoid cartilage, the muscle of larynx present outside is what? Cricothyroid. So these are the two muscles, two tubes, and now we have two muscles also. And those two muscles, the two muscles is inferior constrictor, cricothyroid. And finally, two nerves. One nerve you can very easily guess, guys. What nerve? What is a nerve present in the tracheo-esophageal groove between the trachea and esophagus? That's the recurrent laryngeal nerve. That is the recurrent laryngeal nerve. And another nerve is again very easy to understand. If cricothyroid muscle is there, so obviously the nerve which is supplying the cricothyroid also has to come. So the nerve to the cricothyroid is what? That is the external laryngeal nerve. You can remember it like this way, that some part of inferior constrictor is supplied by recurrent laryngeal nerve. What part was that? Cricopharyngeus. So when you think of inferior constrictor, think of recurrent laryngeal nerve, especially the cricopharyngeus part. When you think of cricothyroid, think of what nerve? External laryngeal nerve. So that way you can remember the medial relation as well. So medial relation is two tubes, two nerves, and the two muscles. So these are the relations of the thyroid glands. Not difficult. If you need to look at the transverse section, if you know about the investing layer of deep cervical fascia, we already know the maximum relations from there. Anterolaterally, we have the strap muscles, sternothyroid, superior belly of omohyoid, sternohyoid, and more outside we have a sternocleidomastoid, which is partly covering the thyroid gland. When you think of the posterior relation is all about carotid sheath and its content. And medial relation, we got to either go with the rule of two. We got two tubes, two nerves, and the two muscles. So that's the relation of the thyroid gland. Relations of the isthmus of thyroid gland are even more important, because in the tracheostomy, the portion of thyroid gland which is compromised is the isthmus. So incision will go through that only. So what structure, what nerve, what blood vessel can be injured when you do the tracheostomy here in the midline? So for that, we need to know the relations of the isthmus as well. But before that, if we go to the blood supply of the thyroid gland, that part will become even easier for us. So guys, let's look into the blood supply of the thyroid gland. I'm going with the arterial supply first. So it will be easy for us to, if we show it diagrammatically, this is the thyroid gland here. That's the isthmus of the thyroid gland. I'm purposefully drawing it big. Superior thyroid artery, as we all know, is a branch coming from the external carotid artery. The first branch of external carotid is the superior thyroid artery. So what you'll see, superior thyroid artery will come here to the upper pole. It gives off a small posterior division, and it also gives off an anterior division which runs on the anterior border and then to the upper border of the isthmus. I want you to keep your eye on the isthmus part here, upper border of the isthmus, where it anastomoses with the branch coming from the other side. This artery here is the superior thyroid artery. That's a superior thyroid artery. And superior thyroid artery in the upper part, it is closely related to the external laryngeal nerve, which then separates. So the nerve that you see in close relation to this artery is the external laryngeal nerve. But then the external laryngeal nerve will separate from it. Inferior thyroid artery was coming somewhere from subclavian. Let me just remind you guys, subclavian artery. Subclavian artery, first part of subclavian artery was giving origin to this trunk that is called as the thyrocervical trunk. So there was this thyrocervical trunk. We already discussed that. And then out of the 3 branches of thyrocervical trunk, one is inferior thyroid artery. So we got an inferior thyroid artery coming from the thyrocervical trunk, reaches the base. One major branch of this will keep running on the posterior border for the majority of the area and anastomose with the posterior branch of superior thyroid. And it also gives off numerous small branches also. So this artery here is what? This is the inferior thyroid artery. Let's say inferior thyroid artery. So guys, superior thyroid artery is a branch coming from the external carotid, the first branch of external carotid. Whereas as you can see, inferior thyroid artery is a branch coming from the thyrocervical trunk, which in turn come from the first part of subclavian. Inferior thyroid artery major course is to be seen on the posterior border, which also tells me that the major supply to the parathyroid gland, which are on the posterior border of thyroid gland, is also by inferior thyroid. So just so that you remember it, I can draw that parathyroid, superior and the inferior parathyroid gland are predominantly supplied by the inferior thyroid artery. If this is a superior parathyroid gland and that's an inferior, so these are the parathyroid glands, and I said the parathyroid glands blood supply, as you can see, it is mainly coming from the inferior. I'm giving it the same shade only. It's coming from the inferior thyroid artery. These are usually present branches, the superior thyroid, inferior thyroid. Now there is one more branch which may be present, not always is there. That is called as the arteria thyroideima or thyroideima simply, which may come from arch of aorta. Let's say if I just draw it in here, that is an arch of aorta. Let's presume this is the arch of aorta, and this is the brachiocephalic artery. We know that brachiocephalic artery goes toward the right side. Arch of aorta, and this is the brachiocephalic artery. So the artery which is going to the lower part of this isthmus or lower border of isthmus is called as a thyroideima. That artery is not always present, but if that is thyroideima is present, it may be coming from the brachiocephalic artery, or it may be coming directly from the arch of aorta. So anything is possible, either from here or from here, either from the arch of aorta or from brachiocephalic artery. That artery is called as a arteria thyroideima. Arteria thyroideima. So that's a third major artery which may be seen supplying the thyroid gland. So in the blood supply and the arterial supply first, superior thyroid artery, inferior thyroid artery and thyroideima. Superior thyroid artery, as you can see, away from the gland, it is related to external laryngeal nerve, but when the artery reaches close to the gland, the external laryngeal nerve is away from it, separated from it. Inferior thyroid artery, away from the gland, is away from the nerve, but when it reaches the gland, you can see the recurrent laryngeal nerve is in close relation. The recurrent laryngeal nerve is in close relation. And the third artery we talked about is the arteria thyroideima, which is either coming from brachiocephalic or from arch of aorta, not from both, it is either coming from these of two. So if you look at the isthmus part, upper border of isthmus, if I talk about artery, it's a superior thyroid artery related to it, and the lower border of the thyroid isthmus is related to the thyroideima. In general conception, we say that concept says that the ligation of the superior thyroid artery should be done close to the gland, and ligation of the inferior thyroid artery should be done away from the gland. Because if you do the ligation of superior thyroid artery away from the gland, then you might ligate the external laryngeal nerve along with it, which we can't afford to do because it's supplying the cricothyroid muscle. And if you do the ligation of the inferior thyroid artery close to the gland, then there are chances of ligating the recurrent laryngeal nerve. So that's why anatomically, if you look into the anatomy books, they say the ligation of superior thyroid artery should be done close to the gland, and inferior thyroid artery away from the gland. But that doesn't go in the surgery. I mean, surgically what we say that the ligation of superior thyroid artery as well as inferior thyroid artery should be done close to the gland only. Whether superior thyroid artery makes sense. Superior thyroid artery ligation is done close to the gland, it makes sense. Inferior thyroid artery, we have many branches, and we have to do the selective ligation of the branches of the inferior thyroid artery, because if we ligate the inferior thyroid artery in the proximal part, somewhere there only, then all the branches are gone and the blood supply to the parathyroid gland will also be compromised. We cannot compromise the blood supply to parathyroid gland. So there is a selective ligation of the branches of inferior thyroid artery is done, but that is close to the gland, and even superior thyroid artery is ligated close to the gland. So remember it, both the arteries are ligated close to the gland only. That's how it goes in surgery. Generally, we say that superior thyroid artery is close and inferior is away from. That is not practical. From the arterial supply and looking at some relation in there, let's come to the venous drainage of the thyroid gland. Venous drainage. Once again, to understand it, I'm going to draw the thyroid gland of only one side. Here is the gland and that's the isthmus. Usually we have three thyroid veins which are draining the venous blood. We have superior thyroid, middle thyroid, inferior thyroid, and sometime a fourth vein is also present. But see, what major veins were we expecting to be present in this region? Like we have an internal jugular vein present in here. That's an internal jugular vein. We know internal jugular vein will meet with the subclavian vein, and then they together will give rise to this brachiocephalic vein. That's how it is. This is the internal jugular vein. Let me just write that. That is internal jugular vein. This one is the subclavian vein. And here we have the brachiocephalic vein. This brachiocephalic vein. If you put these veins in there, that will be easy for you to remember that what vein is draining where. So we have superior thyroid, middle thyroid, inferior thyroid. Now look at this, guys. Superior thyroid vein is draining directly into internal jugular. Superior thyroid vein drains directly into internal jugular. Middle thyroid vein also drains directly into internal jugular. And inferior thyroid vein is actually coming from the lower border of isthmus. Another relation there. Coming from the lower border of isthmus. So obviously what vein you will see here? That is a brachiocephalic vein they will drain into. So this here is the superior thyroid vein. I'm writing in short, that is STV, superior thyroid vein. This one is middle thyroid vein. And this is inferior thyroid vein. So that's a direct question here. Superior thyroid and middle thyroid vein, they're draining into internal jugular, whereas inferior thyroid vein is draining into brachiocephalic. It drains into brachiocephalic. And sometimes there is an additional vein is also seen between middle and inferior thyroid, that is called as a fourth vein of Kocher. And that fourth vein of Kocher, if present, will also be draining into the internal jugular vein only. So that is the one I'm writing 4 here, guys. This is called as the fourth vein of Kocher. If at all it is present, if the fourth vein is Kocher is present, which is not always there, it is going to drain into the internal jugular vein. So all the veins coming from thyroid gland, they drain into internal jugular vein, including the fourth vein, except the inferior thyroid vein, which drains directly into brachiocephalic. So now if you think of the relations of the isthmus, because in the tracheostomy, the isthmus has to be cut here. So when you do the tracheostomy and the isthmus has to be cut, if the question is asked what blood vessel can be compromised. So we have a superior thyroid artery, which was coming in there. Inferior thyroid artery is not there. Which artery was there? It was a thyroidema, which will be seen in this part here. And what vein? Inferior thyroid vein. So when you look at upper and the lower border of isthmus, upper border is related to it's better if you write about the isthmus separately, because it's an important question in case of tracheostomy, the structures which can be compromised. So if you look at the isthmus part, present against the second to fourth tracheal ring, we already said that is the isthmus here. Let me add something to it. There could be a additional lobe of the thyroid gland which will be seen along the upper border of isthmus. That is called as a pyramidal lobe. So pyramidal lobe and superior thyroid artery. Pyramidal lobe and superior thyroid artery are related to the upper border of the isthmus. Where the lower border of isthmus is related to the inferior thyroid vein and artery, if present, that will be the thyroidema. Inferior thyroid vein, guys, only inferior thyroid vein, not the artery, and thyroidema. That's the artery, and that is related to what? Lower border. So all these structures are in relation to the isthmus, and that's why if the question is asked that which of the following structure can be compromised in the tracheostomy, they are the one: pyramidal lobe, superior thyroid artery, inferior thyroid vein, and thyroidema. So that is about the thyroid gland. We talked about the true and the false capsule. We saw the extension of the thyroid gland and the isthmus. We saw which muscle is covering it immediately. What is the modification of the deep cervical fascia covering it and connecting it to the cricoid cartilage. We saw all the relations in the transverse section. And we also talked about the blood supply, arterial as well as venous drainage of the thyroid gland.